Welcome to our Lively U Virtual Learning Academy program. On behalf of the Wood County Committee on Aging, we present our Care Compass project. This project is designed to share resources and information with caregivers throughout the county. The Care Compass project is brought to the community by Brookdale of Bowling Green, the Wood County Hospital, the Wood County Committee on Aging, Ohio Living, Golden Care Partners. Today, we are excited to share with you wound care and diabetes management. The first topic is, what do you know about wound care and wounds? Our featured presentation speakers are Marsha Briscoe. She's been with the Wood County Hospital as an RN for 7 years, and Dr. Richard Walsh, who has been with the Wood County Hospital for 11 years as a medical director and working with the Wound Healing Center at the Wood County Hospital. Please welcome them.
Thank you.
Thank you.
Good morning, everyone. All right, we're going to start this morning. I'll have you, next slide, please.
Okay.
Just a little bit real quick about myself. I've been in wound care for over 13 years now. I've been here at the Wound Healing Center as the clinical nurse manager and now the clinical program director. And then Dr. Richard Walsh has been here with us for 11 years since the center opened, and he is currently our medical director. He also has his family practice here at Wood County on the Wood County Hospital campus. So today what we're going to talk about is we're going to understand the functions of our skin. We're going to learn about the changes in our skin related to age, identify common skincare problems, and then we're going to talk about what is specialized wound care and who needs specialized wound care, the benefits to patients of the specialized wound care, and know when to seek medical treatment for different kinds of wounds. Next page, please. So we're going to go back. We're going to talk about skin. This is the anatomy of our skin. And the skin has 3 layers. We have the top layer, which is the epidermis. We have the middle layer, which is the dermis. And we have the 3rd layer, which is the subcutaneous fat layer. In the epidermis layer, that is the outermost layer. And what that does is that protects our body from any of the external environment, any organisms. The skin, the epidermis, regenerates about every 4 to 6 weeks. So you're constantly kind of losing that skin, it's flaking off and regenerating more skin. The dermis layer of your skin now is a little bit thicker. And what's housed, you can kind of look at that picture in the middle, what's housed in the dermis layer is hair follicles and vessels, and this is the layer of the skin that makes it thick and strong. And then you have your 3rd layer, which is the subcutaneous layer, or what we call the fat layer. And in the fat layer, you have the connective tissue. Next slide. So what does our skin do for us, and what are the functions of our skin? So the skin is the largest organ of our body. And what I had said in the prior screen, it's for protection. That is the main function of our skin. It regulates body temperature. It helps with sensation. It helps with communicating to us, and it helps with fluid and electrolyte balance. So it's helping to keep the fluids in check in our body. Next screen, please. So as we age, there is a normal aging process, and we start to have a loss of the dermal thickness. And if you remember back to that screen of our skin, you had the outer layer, which was the epidermis, the middle layer, that was the dermis. So you start to have the thinning of that dermal layer. You also start to have a decrease in the fat layer, which was the bottom layer of that skin. And because you have those, that they become thinner, you start to lose the strength and the decrease in the collagen fibers in the skin. So that's why as we get older, our skin becomes a lot more thin and a lot more fragile. We have a decreased number of the sweat glands, the function of the sweat glands in the skin, and you start to see a little bit of changes in the blood vessels that are in that skin. Next screen. So because of this, we have common skin problems that happen. As we get older, we start to maybe have more dry, cracked, peeling skin. You may have some weeping of the skin. You may start to see that you're developing blisters. You may have some bumps that develop on your skin that may have some pus in that. You may end up having a more allergic reactions, and your skin will be showing that by redness, inflammation, irritation. And as I mentioned before, as we get older, our skin becomes much thinner, and you are at an increased a chance of having skin tears, pardon me. You also could develop fissures. We call fissures that are little cracks that can develop on your feet or on the dry areas of your skin. And because of these situations we just discussed, you could develop a wound. Next slide, please. So what do we do to help prevent some of that from occurring? It is so important that we care for our skin. So many people neglect their skin. So what do we want to do? You want to keep your skin clean and dry. So make sure after you shower, you're drying off very well. Make sure that you're not scrubbing or rubbing vigorously against your skin. You want to be gentle to your skin. Make sure you're using a mild soap. You don't want to use any harsh chemicals. You don't want to use anything that has a high alcohol content. And even some of those lotions or soaps that have the scents in them, because of that, it has a higher alcohol base, which can dry your skin out. So you want to stick to the plain moisturizing lotions or creams. You want to avoid using any kind of adhesive on your skin, especially some of those really tough adhesive Band-Aids, because if you go to pull those adhesive agents off the skin, because our skin has become more thin and fragile, you put yourself at risk for a skin tear. So making sure that if you are using anything adhesive, that you remove that very gently. If you start to develop areas on your skin that show irritation, redness, bumps, you want to make sure you're monitoring them. And if they continue to get worse and not improve, you want to make sure you're letting your primary care physician know. Make sure that you avoid the sun, or if you're out in the sun, that you're using sunscreen to protect your skin. And then make sure that you are drying and keeping all the areas of your skin, the folds in between your toes. You want to make sure that you keep them very dry. So after you clean, make sure you're patting those all down. And a lot of people throughout the day, their feet will start to sweat. So you want to make sure that you're keeping your feet dry and clean also. Next slide, please. So wound care. There is a growing need of wound care throughout the United States and throughout our country. And the reason being because of the aging population, higher rate of diabetes that we're seeing, chronic diseases, obesity, all these together equal a higher rate of chronic wounds. Next slide, please. So because we are seeing a lot more of these chronic wounds, we want to discuss what is specialized wound care and what are chronic wounds. Dr. Walsh is going to talk to you about the different types of wounds that we treat here in our center and go into a little detail about each of those types of wounds.
Thank you, Marsha. So I'm going to go over some of the wounds that we see. When a patient comes in with a non-healing wound, a wound that they're having trouble getting to heal by ordinary methods, we look at the wound and we try to figure out what the cause of the wound is in the first place, because that gives us a clue as to how we're going to heal it. You're probably used to growing up and getting cuts and scrapes and almost virtually ignoring them, and they still heal, like you're just invulnerable. And so it's very strange to suddenly in your life come across a wound that doesn't heal. And it's very perplexing. It's even perplexing for us sometimes when we do all the right things and the wound is still stubborn and resistant. So I want to go over some of the types of wounds that occur and perhaps why they have trouble healing. And then we'll talk about the things that we do to try to improve the chances that it will heal. So this is kind of a summary slide here. We're going to talk about venous ulcers. We're going to talk about pressure ulcers. We're going to talk about diabetic ulcers, arterial ulcers, which are ulcers due to poor blood supply, vascular insufficiency. Osteoradionecrosis is due to radiation,
yes.
and really it's delayed radiation tissue damage. Some people, as part of their cancer treatment, undergo radiation treatment. That damages the skin and the blood supply, and then it's much more difficult to heal wounds in that area.
And it can damage the bone in the jaw area from the radiation. And so people can develop ulceration or even problems with the bone.
We also have just plain skin irritation, surgical wounds, which are a big category, and we'll talk about that, and neuropathic ulcers. Neuropathic meaning that the person cannot feel sensation on their skin, and as a result, they're prone to get a wound and not know it's there and then ignore it, accidentally, of course.
Next slide, please.
So many people suffer for years, even decades, with wounds such as these, and we're going to go over some of them in more detail. We're going to show you some pictures. We talked about whether to show pictures or not, and I said I think they'd be interested in pictures. It really brings it alive and lets you see exactly what these wounds look like so you can recognize them and see what the challenge is in getting them to heal. And up in the corner on the left, you'll see venous stasis ulcers, which we're going to talk in more detail about, pressure ulcers, the soft tissue radionecrosis, radiation damage, and then finally diabetic foot ulcers, which are very difficult to heal.
Next slide.
And so venous ulcers are venous insufficiency ulcers. Our leg receives blood via the arteries. So fresh blood comes from the heart, travels down the leg all the way to the foot through arteries, and then it returns through veins. When it returns through the veins, there's no heart down at the bottom of the foot to pump it back up. So our calf muscles, as we walk, compress the veins, the blood moves up, and then one-way valves shut. So as the blood passes through, the valve shuts and doesn't allow the blood to travel backwards again. So in a series of steps, it goes up our legs and returns to the heart. As we age, those valves degrade and can break. Due to other issues, they can break. Some women experience it young, just from pregnancy and the back pressure of pregnancy that causes on the lower extremities. Obesity can cause it. And there's some people that have weak valves due to heredity as well. The result of this is that blood is traveling in two directions. It's traveling down your leg from your heart, but it's also traveling back. Instead of away from the leg, it's traveling back in the veins, back down the leg as well. This results in increased pressure in the leg itself and in the calf particularly. This causes fluid to leak out from those blood vessels into the skin, and this causes the leg to swell. This is the most common cause of swelling in the legs. So I see a lot of patients in my practice that are concerned about swelling in their ankles. And usually the story is it's good first thing in the morning, but as the day goes on, they start developing some swelling in their legs. This is most commonly due to venous insufficiency, and that's the word we use for these broken valves. Now, if there's enough fluid in that skin and enough pressure, then the skin itself dies and we get these open ulcers. And this is typically how they look. They start out as a blister and then they can get very, very deep because the problem is the fluid's still in the skin. So there's no reason for that to heal. It broke down in the first place because of fluid. So if you don't get rid of the fluid, how's it going to heal?
Next slide.
These are common areas for venous leg ulcers. So the most common, as you see, is in that stocking area right above the foot. Less common are above and below it, although we do see those.
Next slide.
Talking about treatment.
As far as treatment for the venous insufficiency or the swelling in the legs, when they come into the wound care center, we always do what we call our ABIs, or ankle brachial index, for these wounds to make sure that the patient has adequate blood flow going down to their feet, because the last thing we want to do is to cut off the blood flow. So we check the blood flow, 1, to make sure we can debride the wound, and 2, that we can compress them. So the gold standard treatment for a venous leg ulcer is compression therapy. And we have specialized compression wraps that we will put our patients in to help heal these wounds, along with specialized dressings.
And it's not uncommon that we see someone come in that's had a wound on their leg for months, and we put compression wraps on, and within a few weeks they're healed. So the compression wraps squeeze the water out of the skin, don't allow it to reaccumulate, and that alone often heals these.
And then it's usually compression for life. So we set the patients up with some kind of compression garment then to help maintain and prevent wounds from reoccurring.
Such as support hose. So the next category is arterial ulcers. So like I said, the blood is traveling from the heart down to the legs. But what if those arteries themselves have trouble? Just like a pipe in an old house, the arteries can become corroded and narrowed. And if there's lack of fresh oxygenated blood traveling to that skin, then that skin can't live.
Next slide, please.
So these are typical areas where we see what we call arterial ulcers. So we're calling these arterial, the others were venous. And these are serious and much more difficult to treat because a compression wrap won't work on these. In fact, it would make it worse. So these are people who perhaps were smokers, have diabetes, have a family history of what we call atherosclerosis, and have developed blockages in the arteries leading down to their legs. They typically require a vascular surgeon to get involved and to evaluate them and see if perhaps they're a good candidate for some sort of a surgery, such as putting a stent in, which is a little pipe to open up the artery. And if that is the case, then these ulcers heal up very well afterwards.
So how we would treat an arterial ulcer is we would not be real aggressive with debridement or cleaning the wound. We would want to find a dressing that's going to help keep the wound moist and infection free. And then we would bring in a vascular surgeon to work with us, like Dr. Walsh had said, to establish blood flow to those areas to help heal the wound.
So we're fortunate to have a vascular surgeon right here at the Wound Healing Center as part of our staff, and he's here every week seeing patients. So it's as easy as me saying, schedule him with a vascular surgeon next week, and they get a hands-on approach, and we make that determination and move quickly to get the patient healed.
And I'm not sure if you could tell by the pictures, but you could kind of see a difference between the venous and the arterial. A lot of times arterial wounds will present as black in appearance, and that's because it's ischemic or there's not blood flow to that area and that tissue is dead. The venous are a lot more, and they're dry. They're very dry and very painful. With the venous wounds, they're usually very large, not quite as painful, and they drain a lot because that fluid is trying to get out of the leg, and it's going to go out of the path of least resistance. So that's the two differences between the arterial and the venous characteristics of the wounds. Next slide, please.
So next category are pressure ulcers. So a pressure ulcer used to be called a bed sore. And it's really very simple mechanism. The mechanism is if I put pressure on my skin and don't take the pressure off, I'm squeezing the blood vessels closed. And that skin, just like the arterial ulcers, cannot survive without blood. So the skin will turn a little dusky red, and it may develop a blister. It may start to slough. Frequently, even at that sign, the wound is very deep. These pressure ulcers can be very, very deep. They occur over what we call a bony prominence. That is an area of the body that has a bone sticking out that's more prominent than the surrounding area.
Next slide, please.
And these are, it's sort of a map of the typical areas that we see. So if you can imagine someone lying on their back in bed, then these are where bones are sticking out, and these are where they tend to get skin breakdown. So if they are not lying in bed, then, or they can get up, then it can prevent that. At any rate, these wounds get very, very deep and often require a real team approach to get them well. We do something called debriding, which means we are cutting away dead tissue from the wound. If there's dead, non-living tissue in the wound can't heal. Sometimes we do that right here in the office. Frequently we do. But if the wound is deep, then they have to be taken to outpatient surgery. And one of the surgeons usually gets involved and helps us with that.
So if you're caring for a loved one that's bedridden or in a wheelchair, prevention is the #1 treatment to prevent pressure ulcers. So reducing pressure, I should say. So you want to watch all those areas, the elbows. If they sit with their arms on a table, you want to make sure you're monitoring the elbows and getting pressure off that area. Heels are another big area where we see a lot of pressure ulcers that develop from people laying on their back in bed, or if they sit a lot with their legs elevated, you'll start to see breakdown in the heels. How it usually starts is a little reddened area, and when you push that reddened area, if it does not change color, then you know you're starting to get in trouble. You need to get pressure off those areas. And it can be as simple as free floating the heels by putting pillows under the back of the legs to make sure there's no pressure on the heels. Just repositioning. If somebody's sitting in a chair and they're watching TV, we say every time a commercial comes on, reposition, switch your weight from one side to the other, or stand up and just stretch, sit back down. If you're laying in bed, making sure that they reposition at least every 2 hours, turning from side to side, using pillows to help keep pressure off those areas. So prevention is the main thing that we try to do. Once a patient comes in, if they've already developed a pressure ulcer, then we have the specialized dressings that we will use, along with, we continue with offloading with special bed mattresses, wheelchair mattresses, possible surgical debridements, and different advanced treatments that we use here in the center.
Our main tool for healing pressure ulcers is getting the pressure off the area. And without that, anything we put on the wound isn't going to make any difference. So the two most common areas are the lower back and buttocks and the heels. So if you have someone you're caring for, those are the areas you want to watch especially. And the heels will get away from you. you won't notice. They're sitting in a recliner and everything looks okay. It won't occur to you that their weight has been on the heels all day long. So
Next slide, please.
diabetics often develop something called a peripheral neuropathy, and that is an abnormality where the nerves no longer carry sensation of the skin back to the brain. People with peripheral neuropathy do not feel things in their feet the right way the rest of us do, almost like, they've been numbed up for surgery. And as a result, they can step on tacks, they can develop little blisters or sores and not even know that's going on. So typically the problem here is that there's delayed response on their part to seeking medical help or even seeking their own attention. They don't know the sore's there, so they don't stay off their foot, they don't treat it, and it progresses very quickly. Because of the diabetes that's there as well, there is also delayed wound healing. So a diabetic has more trouble healing a wound than a non-diabetic. And then that can vary among diabetics, whether their diabetes is well controlled or poorly controlled. So it's a real setup for a very difficult wound, a non-healing wound. We typically see these in the feet, and we typically see them on the bottom of the foot, on the toes, even on top of the toes because of shoes. Anywhere that the skin can rub and cause a sore, we see these.
Next slide, please.
So ulcers start probably most common from poorly fitting shoes.
Next slide, please. Oh, they must.
Oh, I see. I don't know how this works.
Thank you. There we go.
So poorly fitting shoes, as we walk, our foot moves ever so slightly back and forth within that shoe, and this causes a blister. The blister causes skin breakdown and then often can lead to a deeper wound. Sometimes it causes a callus. So it may look harmless. You may look at someone's foot and just see a callus there. Well, why is the callus there? The callus is there because the foot is sliding in the shoe. And it's, again, this is over a bony prominence, similar to the pressure ulcers. Also, this can occur, an injury can be sustained while walking barefoot. Some people see something on their skin, peeling skin or a callus, and they try to pull on it, and they pull the skin right off with it. Or they use something over the counter to try to cure it. Under these calluses that can look harmless, often there's an ulcer. So we get patients come in complaining of foot pain. We see a callus, we pull the callus back, and there's a deep hole underneath. So they're not harmless, and they're worth taking seriously. Trimming toenails with poor eyesight and clipping the skin by accident is common. And moisture between the toes causes skin breakdown. So sweating and not getting out of your shoes, not drying the skin out can cause it as well.
And we recommend anyone that is diabetic to make sure that they're getting their nails trimmed by a podiatrist because they have the proper tools. And usually insurance will cover for them to have that done a couple times a year. So if you're diabetic, that might be something to look into. Next screen, please.
These are common areas for skin ulcers. Usually on the top of the toes, it's due to the shoes. And on the bottom of the toes, it's due to poorly fitting shoes. Diabetics are, what's the rule for getting diabetic shoes when you're diabetic?
So with diabetic shoes, you are actually allowed custom shoes and inserts to be made every calendar year. So you can get one a calendar year.
Without an ulcer?
Without an ulcer.
That's
Yes.
Medicare's rules.
That is Medicare's rules.
Next slide, please. And this is just a slide to show you the skyrocketing incidence of diabetes in America. So along with diabetes going up, the peripheral neuropathy increases and the non-healing diabetic wounds increase as well.
Next slide, please.
This is to show you how serious this is. The mortality rate is due to can be due to the wounds themselves. As we see here, we might not be surprised that someone with pancreatic cancer has a high mortality rate. And these are called 5-year mortality rates. They mean within 5 years of diagnosis, you die. So we're not surprised to see pancreatic cancer, lung cancer. PAD is the arterial disease we were talking about. But look at this, ischemic ulcer. An ischemic ulcer means an area of the skin that broke down due to poor blood supply. It has a very high death rate within 5 years. Any leg amputation, and leg amputations typically are due to non-healing wounds and bone infections. And then the next one down is neuropathic ulcer, which would be the diabetic ulcer. So prevention and quick treatment are very important.
Next slide, please.
Surgical wounds don't always heal the way we expect. The surgeon may do a wonderful job and the surgery was a success and the patient's wound is repaired. But within the next week, due to multiple factors, though some of the sutures may break, the wound may pop back open, and the wound may be very, very stubborn to heal. We do treat those as well. They do require a doctor's care in a specialized wound healing center, or perhaps your primary care physician could address it themselves, but we find they're very stubborn, and we have specialized products and methods to helping them heal. So this is just a category to let you know about.
And we continue to work with that surgeon if they refer the patient to us. We take over the wound care, but we keep that surgeon in the loop of the treatment. Next slide, please.
So these are atypical wounds are due to other unusual diagnoses, rheumatoid arthritis, something called pyoderma, and something called vasculitis. These would occur spontaneously, be very resistant to healing. We typically would biopsy them. That would give us a clue as to why they're not healing. And then in combination with help from a rheumatologist, we would work to get them healed that way.
Next slide, please.
These are some causative factors for atypical wounds. Brown recluse spider bite, post-radiation treatment, which we mentioned, skin cancer. So you get a non-healing wound, and it could just be a skin cancer, but it just doesn't heal. In fact, it starts getting bigger and bigger and bigger. If we're suspicious, we biopsy early just to make sure we don't miss those. And then autoimmune process refers to things like rheumatology type issues that can occur.
Next slide, please. So a little bit about our center. Our center here is provider driven. And what does that mean? It means that whenever a patient is here, they will be seen by one of our wound care providers that have had specialized treatment in wound care. We follow an interdisciplinary approach, meaning we work with the primary care physician. We work with the hospitalist. If there's patients that have been admitted to the hospital and they have a wound, we are working with them and getting the patient referred to our outpatient wound care center. If they're in the emergency room, we have a system set up with them also that they can be referred out to the wound care center. Again, we work with primary care. We also work if a patient has an endocrinologist, especially the diabetic foot ulcers or lower extremity wounds. In order to help those wounds heal, we need to make sure that the blood sugars are being controlled. So we will work closely with the endocrinologist. We work with infectious disease. We do not have infectious disease in our center, but we have some in the surrounding area that we work very closely with. And that would be if there is a resistant or a bacteria in the wound that's very difficult to treat, or if there's a bone infection, we bring infectious disease into the care because they have the specialized knowledge to treat those different kind of bacterias. We work with general surgery if we need any kind of surgical debridement that cannot be done here in our center. And then any other specialties, if we're having, we talked about dermatology, somebody comes in and if it's a skin cancer, we work closely with dermatology just down the hall. So we want to find out the cause of the wound. When they come in here as a patient, we're just not putting a dressing on the wound to heal it. We want to find out why this wound is not healing and what we need to help it heal. Next slide, please. So what we look at when you first come into the wound care center, we do a full history and physical on the patient. And we try, when it says define the etiology of the wound, we're wanting to figure out what is the cause of the wound. Is this wound here because of their diabetes? Is it here because of poor blood flow? Is it because of the venous insufficiency Dr. Walsh talked about? So we check every patient with a lower extremity wound for adequate blood flow. We look for if there's any presence of non-viable tissue, which Dr. Walsh had mentioned that sometimes there's dead non-living tissue that needs to be cleaned out of that wound in order for it to heal. We look for any signs of infection. We do cultures, tissue cultures, and then if there's any bacteria growing in that wound preventing it from heal, then we will treat that with antibiotics. We look for swelling, as we talked about with the venous insufficiency, and starting compression therapy on these patients. We want to make sure that the wound has a really good environment to heal. It used to be keep the wound dry, let it scab. All the clinical research out there shows that you need a moist wound healing environment. So we have specialized dressings to keep that environment controlled. We want to make sure that we're allowing for proper tissue growth in the wound. So making sure that we're keeping that wound clean, using proper dressings. We address nutrition with our patients. You need a lot of protein, vitamins, minerals to help heal these wounds. We want to make sure that they're offloading. So if it's on the foot, if it's on the back, on the bottom, we want to make sure they have the appropriate devices to help keep pressure off those areas. We try to control pain here with the patients. We work with the primary care physician to help with pain management. And then we just look at the overall picture to make sure that we are giving that wound bed the proper environment to heal. Next slide. So our center does a lot of advanced treatments in wound healing. We have hyperbaric oxygen therapy. We do surgical debridements here in the center. We do negative pressure wound therapy. We do compression. And then we also utilize what we call cellular-based tissue or skin substitutes that add the collagen, the growth factors that your wound is lacking to help facilitate or speed up that wound healing. And these are advanced treatments that usually are not used in a primary care facility or in a hospital because of the advanced because it's an advanced treatment, you need to have extra education and know how to use the products. Next slide. So hyperbaric oxygen is part of our treatment modality or our treatment approach for some of our patients. Hyperbaric oxygen is the use of 100% oxygen that is applied at an increased atmospheric pressure. So wounds that can be treated with hyperbaric oxygen could be an ischemic ulcer, meaning they don't have the blood flow. It could be a bone that has infection that has not responded to debridement or to antibiotics. It can be a crush injury where it's threatening of that limb. We use it for diabetic wounds, and we consider the patients that have a diabetic wound, they have to be what we call a Wagner grade 3. So that means that they have a wound and it's either muscle, bone, or tendon is infected. We use it for the osteoradionecrosis, where they've had the radiation and we have some bone involvement now. And we can use it to help if somebody had a skin graft and that starts to fail. The hyperbaric oxygen can help salvage that skin graft. And then we can use it for the soft tissue radionecrosis. Next slide, please. So how hyperbaric oxygen works, and I'll let Dr. Walsh explain more too. But what it does is you are compressed in 100% oxygen. And what that does is with the pressure and breathing in the 100% oxygen, that oxygen is pushed into the plasma and gets to the area where your oxygen, your main vessels cannot get that blood. So it helps to give that nutrients to those areas that are lacking the blood flow.
Typical course of treatment involves a patient spending about 90 minutes a day in the chamber 5 days a week over a 4 to 6 week period. So it's a big commitment. We need the person involved to understand that. So first of all, they have to have the right kind of wound that's approved by Medicare and their insurance company. Second of all, they have to be willing to do such a thing, to come in every day and be committed to this. However, using HBO can significantly speed up the healing of a lot of these wounds. And so if you look at the long-term goal, it saves you a lot of time.
It reduces swelling, it fights infection. So oxygen is actually one of the top antibiotics or antimicrobials against any kind of bone infection. It helps what we call, it creates angiogenesis, or helps with angiogenesis, which is the building of new blood vessels. So if you have areas that are lacking that blood flow, it can help to stimulate the growth of those new blood vessels. And therefore, by doing all that, you increase or speed up the wound healing process. Next, oh, sorry. So could you go back a slide? Sorry. So who may benefit from our specialized care? Both acute and chronic wounds are seen here in our wound care center. A chronic wound is a wound that has not healed over a period of time in a timely manner that you feel it should have healed. Acute wounds are wounds that may have just happened. We see both kinds of wounds. We've had patients that have gone to the ER with huge skin tears and they're not able to suture those up, or should not be sutured up. So they come over to us for us to care for them. A lot of our patients have a lot of complicated conditions, a lot of what we call comorbidities, such as diabetes, respiratory, cardiac issues, and that all affects the wound healing process. So we see wounds that have not healed in a timely manner. Next slide.
When to treat a wound at home. So minor cuts, scrapes, punctures, not more than 1/4 of an inch deep, may only need basic wound care treatment at home. Initially, you would clean the wound with just mild soap and water. Remove any visible dirt or debris. If it's bleeding, apply some gentle pressure. That bleeding will stop with pressure. Apply a bandage, but before you put that on, we want you to put a thin layer of antibiotic ointment on. This is to get the benefit of the antibiotic, but also to help keep the wound itself moist, because it provides a seal over the wound. And then you can cover it with a Band-Aid, or if it's bigger, a nonstick gauze and roll gauze. We don't like you putting tape on your skin. We don't recommend that because the tape can cause a wound. So a good thing to invest in actually is roll gauze. And so the way it works is you buy little squares of non-stick gauze, just like on a Band-Aid, Put that directly onto the wound, and then you're going to put roll gauze around that, assuming it's on an area of the body that you can roll gauze on. And that way you tape the gauze to itself and you don't put tape on the skin. And then as you watch it over the next few days, you clean the area. It says here twice daily, but you might get by with just once daily. And continue this until the wound is fully healed. Minor burn wounds, you'd want to run cool water over the area to cool the area down. Apply a cool wet cloth. If blisters form, do not pop or drain them. Next slide. Wounds on the face or reaching bone, even if only 1/4 of an inch deep, would be worth seeing one of your medical care providers for. Deep or gaping wounds that need stitches, well, if they're within 6 to 8 hours, they could still be stitched. So you might want to go to an urgent care or emergency room, or you call your physician if they're open. If it's been more than that, then call your physician's office the next day and have it looked at.
If you have an animal or human bite, those can be serious. You want to make sure you seek medical profession from your primary care physician, or if it's an animal bite, you might want to seek help at the urgent care or the emergency room. An injury that's caused by a rusty object, you want to make sure that you're seen by your provider or by the emergency room to have that cleaned out and to make sure you have your tetanus shot.
Make sure it's up to date.
Yes. If bleeding does not stop after 10 minutes of pressure, you probably are going to want to either go to the emergency room or call 911. When we say pressure, that means 10 minutes of continuous pressure. You do not want to release that pressure at any time. That should stop the bleeding, but if it continues, then you need to seek medical help. If normal healing does not occur, despite your standard care, everything that we told you by cleaning the area, putting an antibiotic cream, keeping it covered, then your wound is now turning into a chronic non-healing wound. And there could be an underlying cause of that. If it's infection, if it's blood flow, if it's a skin cancer, there's many things that it could be. So you want to make sure that you seek medical help and not just let it continue to go. Okay. If your wound has not healed in 2 weeks or completely healed in 6 weeks, you want to make sure that you're seeking medical advice. Here at the Wound Care Center, we are self-referral, so you do not need a physician's order or a physician's referral to be seen by our providers. We do recommend that you do see your primary care first, and they can send a referral, but if you don't have a primary care, you can do a self-referral to us. Next slide.
So sometimes a wound that's seen minor at first can later develop an infection or just fail to heal. Contact a doctor if you have any of the following: redness spreading out from the wound, increased pain or swelling, difficulty moving the affected area, pus or odorous drainage, warmth around the wound, fever, any fever at all, higher than 100.4, and poor healing.
Next slide, please.
When wounds don't heal and they're still painful despite treatment, it's time to see a specialist. At the Wound Care Center, we will do all the things that we've just spent the last half hour talking to you about, and put an appropriate dressing on, as well as try to figure out the cause of the wound and reverse the course of that wound.
Next slide.
So the benefits of an advanced wound care, such as we provide here, are faster healing, shorter recovery time, limb salvage. We do not want you to lose your toe, your foot, your lower leg. We work very hard to prevent that. And we have a good team that all works together to prevent that. We want to restore your health. We want to get you back to walking and enjoying life. And also we want to educate you, help you understand what's going on, just the way we have here. We'll explain everything. We want to prevent any new complications. And then once you're healed, we don't want that wound to come back. We're happy to see you just once and never again.
And we make sure when you're discharged from our center that you have the proper devices that you need to help prevent wounds from reoccurring. Next slide, please. That is the end of our talk. Is there any questions?
Yeah, I'm going to go ahead and share a question we have in the chat room today. So the first question is, are there measures that can be taken to avoid cellulitis? If it exists, should it be wrapped 24/7?
So measures to avoid cellulitis is what we had talked about, is making sure that you don't have any of those cracks in your skin. You have even the minor little crack, you can get bacteria that's introduced into the skin that can start cellulitis. So skincare is one of the best preventions to prevent cellulitis. Making sure you're keeping it clean, using moisturizer to prevent any cracks from occurring. Once cellulitis is diagnosed or told, if there is an open area, then yes, a dressing should be applied to that area and changed daily. But that dressing should stay on 24 hours a day. You don't want to open that up to the environment and allow more bacteria to be introduced into the opening in the skin.
If there's no open wound, however, you just have redness of the skin, then there's no reason to put a dressing on that. So like Marsha said, the most important thing is to prevent it by hydrating your skin, taking good care of your skin. If you have a chronic skin rash on your lower legs, that may be due to venous insufficiency. So wearing support hose and perhaps using a steroid cream can prevent that.
Perfect. The next question is bursitis in the elbow. Should it be wrapped? Wondering if wrapping is the best, or should you leave it unwrapped at night?
So I don't think bursitis heals any faster by wrapping it. It's going to take time. I think the person asking about it is probably talking about that Popeye elbow where you can see the bursitis as opposed to just a painful elbow. As long as there's no infection involved. But bursitis in the elbow can turn very red, and sometimes cellulitis can coexist with that. But I would say that wrapping it probably doesn't add much to it. If you're more comfortable wrapping it, then go ahead.
Perfect. I'm going to go ahead and see if there are any other questions from anyone. All right. Well, if not, we can go ahead and they can share their questions, and I'd be happy to bring them to you if we do get questions later on.
Okay.
That sounds good.
I want to take this opportunity to thank you so much for sharing your expert knowledge with us on wound care and providing this great information as a resource for the community. Just as a reminder, it will be shared on our YouTube channel, Wood County Committee on Aging, Inc. And we thank you so much, Dr. Walsh and Marsha, for joining us today.
Thank you.
Thank you. It was our pleasure.
We are going to go ahead and start our next featured presentation for our program today. And I am happy to set this presentation up and introduce our topic on diabetes management as a caregiver. And I'm welcoming Kerri Knippen here from Bowling Green State University as our speaker today.
Hi, Danielle. Thank you very much for the introduction, and I'm happy to be here today to present on this topic. So as Danielle said, my name is Kerri Knippen. I'm a faculty member at Bowling Green State University. I'm actually in our food and nutrition program. I'm a dietitian, and my background has been in diabetes education. So it was interesting to kind of dive into this topic a bit. I talk mostly about nutrition in my role as a dietitian, but certainly caregiving does come into play within that realm as well. So we will be talking today about caregiving and diabetes. And I guess, Danielle, can you advance the next slide? Thank you. So we'll talk about how diabetes impacts more than the person living with diabetes. We'll describe ways that caregivers may be involved with diabetes care. And I'll also talk about ways caregivers can manage their caregiving roles and stress that may be associated with caregiving, specifically related to diabetes. So first I want to start with what is caregiving? Caregiving can be provided from a paid or unpaid person. And it's basically somebody who helps provide care for another person. Care can help improve stress, social support, and reduce the burden of managing a chronic disease for a loved one. Caregivers can help with the activities of daily living. And so when we talk about that, that would be things like helping with preparation of food or helping with self-care behaviors. And there are a lot of self-care behaviors that come into play with relationship to diabetes management specifically. Next slide. So I like this quote when I was looking at, again, some of the literature. This one popped up to me, and it's from Rosalind Carter. And she says, who is a caregiver? There are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need a caregiver. And I imagine many of you at some point in your life have been a caregiver to somebody, whether it was your children, a family member, a friend, spouse, partner. We've all provided care to someone at some point in our lives. Next slide. So approximately today in the United States, more than 25% of adults report that they provide care to someone, a loved one that's living with chronic illness or disability. The average age of a caregiver is 49 years old. And that actually somewhat surprised me. So we're thinking again about our aging population. It may be a child of perhaps, the parent that they're providing care to. So in adult children, we may also see that adult grandchildren may be the caregiver for, an elderly grandparent. So I found that quite striking that about 49 years of age is the average age of the caregiver. Next slide. So who can be a caregiver? I mentioned some of the, again, it could be paid or unpaid. There can be what we call formal and informal caregivers, which I'll talk about next. But a caregiver can be a spouse, it could be your partner, siblings, children, friends, loved ones. But there are many other types of relationships where people may be providing care. So I'll take maybe just a moment from the audience. I don't know if that's okay, Danielle. Are they able to unmute themselves?
Yeah, I can go ahead and assist with that.
Okay, cool. I have a few of those throughout the presentation, so I apologize. I should have let you know that in advance. So if you can think of anybody else that could be a caregiver, feel free to share that in the microphone. And if not, if we don't have any other options, that's okay too. So another type of caregiver that would be a paid caregiver. So go ahead to the next slide, Danielle. So those are what we call formal caregivers. And this could be somebody that maybe you receive assistance from a home health agency and they come into your home. Maybe they help you with, things around the home in terms of your care. It could also be somebody who comes into the home and again is a paid relationship where they maybe help with grocery shopping or cooking and those types of activities. So that's another form of caregiving. So it may not always be a close family member or friend or somebody that you have in terms of your familial relationship who's providing care. Next slide. So about 78% of older adults will have weekly contact with their adult children outside their home. So I think it's important to recognize, especially this last year because of the pandemic, a lot of people maybe were having that contact virtually, and caregiving can happen outside the home. It doesn't always have to be directly in the home. Caregiving can happen through long distance types of formats as well. So things like Zoom, meeting with a family member to talk about their care, talking with somebody on the phone about their care. Those are also forms of caregiving as well. Next slide. So I want to talk a little bit about diabetes distress. And when I talk about diabetes distress, we're really talking about anxiety or stress that's related to the diabetes self-care. So when we think about diabetes, people are often, those living with diabetes, asked to check their blood sugar several times a day. They might be asked to read food labels, to monitor the amount of carbohydrate that they're consuming. They have regular appointments to their primary care provider and other specialties they may be seeing. So all of these types of things can at times lead to additional stress or burden on the person living with diabetes, but also the family members. So a study is called the DAWN-2 study looked at how diabetes distress also impacts caregivers and family members. So over 2,000 family members participated in this study. And what they found is that distress was really high among family members comparatively to the actual person living with diabetes. And distress was often related to concerns with self-care, and in particular, hypoglycemia, family members being quite concerned about low blood sugar for their loved one, right? So that can be quite a distressing situation if you've seen a loved one have a low blood sugar, especially if they needed medical treatment to treat that hypoglycemic episode. So distress can occur in many forms, not just for the person living with diabetes, but also for the family member or those providing care. I think it's interesting that today we have several women on the meeting, and maybe that's normal, but I wonder if it's because many of you, again, were perhaps, again, a caregiver at one point in time, or you may be a caregiver for a loved one. We do find that caregiving responsibilities and workload tends to fall more on the burden of women in today's society. That workload related to diabetes caregiving specifically is higher among those who are married, higher among women, and also those who identify as a homemaker. So I think that's interesting that, for individuals who identify in terms of their employment as a homemaker primarily, that they have actually a heavier workload for their caregiving responsibilities for their family member with diabetes. There might be several reasons for this, and maybe that partner became independent or dependent upon them over the years. And maybe that, those types of responsibilities were already carried by that partner. But I do find it interesting that we have several women today on the meeting. So I wonder if you maybe have fallen into this boat as well. Next slide, please. So another study looked at kind of, how family and caregiving was related to diabetes and how it might facilitate diabetes management, help diabetes management, and then also what might be a barrier to somebody's diabetes management. So first talk about the facilitators, so things that enhance diabetes management. Family watchfulness. So when I say family watchfulness, we're talking about how the family member might be able to identify changes in clinical status, such as low blood sugar, right? If I know that my family member becomes irritated or angry, or just their color, their pallor might change when they're having a low blood sugar episode, that may be something that I start to watch, and I'm vigilantly monitoring that, especially if I'm concerned about hypoglycemia for a loved one. So family watchfulness can sometimes be a facilitator to diabetes management. An extrinsic motivator is that families can sometimes act as a motivating factor for the loved one with diabetes. So in one way, as a caregiver, you might learn from your family member who has diabetes that you're providing care to, but you might also motivate them and provide a desire for them to be involved with family events or future family events that might help with their self-management. So there can be a mutually beneficial motivation there. The next one is positive care partnerships. So when we think about that, we're talking about how caregivers and the family member with diabetes, how they can share maybe perhaps health-related goals. Maybe they can share information and resources to help one another. It may also be that they do exercise together. They go for a walk together. They help prepare meals together. Those positive care partnerships as part of the caregiving and family relationship can really enhance diabetes management. Where negative relationships in that respect could have, the opposite effect. So having a family member who, again, helps provide care related to activities of daily living, shopping, reading labels, maybe helping provide financial support and resources. Those types of positive relationships can have benefit for diabetes management. And then the last facilitator that was identified from this study was independence from family. So actually the person living with diabetes needs to develop their own personal capacity to manage their diabetes. And this is something that that stood out to me because I remember actually a client that I had many years ago who had had diabetes for several years, and his wife did a lot of his self-care, and it was a big burden on his wife. She needed to prepare every insulin injection for him. He didn't want to do it on his own, and that really limited her ability to do things outside the home as well. So it was having its toll on her. So we really, worked with them as part of the diabetes education just to develop some of his own independence, that yes, he could prepare his own insulin injections and draw them up. We moved him to insulin pens, for example, to make that easier so that he felt more independence and able to do that on his own. And then she was able to, again, kind of step away and pull back from that. But that independence is really important, and that can help facilitate the caregiving relationship, but also the own personal self-management of one's diabetes. So while it's important that we provide care to our family members, we need to make sure that they're also, the person with diabetes is able to develop their own self-management capacity. It's also important because that will allow the caregiver to start prioritizing their own health and, separating themselves from their caregiving responsibilities 24 hours, 7 days a week. And so the next section of this study looked then at barriers to diabetes management. So obstructive barriers can be damaging to diabetes management and self-management goals. And this would be thinking about somebody who feels as though their partner or caregiver is sabotaging their self-care or their efforts for their diabetes care. So if, for example, I prepare a pie 3 days a week, and that's going to be something that's going to be difficult for the person in my home living with diabetes to portion control and moderate their intake, then that might be that I'm sabotaging their self-care efforts, right? And I may not mean to do that. I might be, have the best of intentions for preparing maybe something that they like or they enjoy, but we want to be careful about how that can happen. Other things could be changing routines, changing, again, food habits, or just difficulty managing the family role and the caregiving duties. So that's where sometimes that formal paid caregiver can come in and kind of remove the family member from that caregiving relationship at times. Limited capacity or family support can also be a barrier to diabetes management. So, really having a lack of family engagement. It could be, that the family member simply doesn't have the knowledge to prepare healthful meals, for example. So I'll talk about nutrition a lot just because that's easy for me to talk about and reflect on. But, if I have a caregiver who's always prepared food a certain way, it would be important that when the patient comes in to see the registered dietitian, they bring that caregiver family member along so that they can receive education on changes they could make to how they prepare food or serve food. Again, it may be just simply a knowledge deficit that needs to be fulfilled. It could be simple things like not walking or doing exercise together, or not developing an empathy or understanding for the person living with diabetes and how it might have impact. It can also go the other direction, right? So if the person living with diabetes is not engaged with the caregiver or doesn't want to have that type of engagement with the caregiver, that can create distress upon the caregiver. So a lot of these relationships can go back and forth where the caregiver can also receive, undue stress and distress because of maybe how the person living with diabetes responds to them or reacts to the situation. Next slide, please. So I want to talk a little bit about some of our, again, a little bit more about family and caregiving and how that might impact diabetes management. Family communication is going to be, critical, and that comes into play with anything, but especially when a person is living with chronic disease. So having, just positive talk and positive communication, keeping the lines of communication open can be helpful. I think it's also important, again, for people to think about how they communicate about disease within their family. So past family stories or messages about diabetes, especially if they were somewhat traumatic or had a negative outcome, that can have a negative impact on the person living with diabetes. And it can also create additional stress for the person who's helping provide care. If we're constantly worried about, so-and-so had this outcome, right? That doesn't mean that your loved one is going to have the same outcome. So we want to make sure that we think about, again, how we communicate about the disease and, how we message maybe other family stories related to diabetes, for example. Family rituals, traditions, those things may need to be changed or perhaps, adjusted over time as a result of one's diabetes self-care. And that's, again, where it's important to have that family communication to help, identify ways that the family can make those changes together. And then we're going to talk about coping a little bit later, but a study found that communal coping, and this was, again, a mechanism of teaching family members how to communicate with one another. When that coping was positive, it helped provide support and encouragement for lifestyle change for the person with diabetes from the family member. And then negative communal coping would be things like lack of togetherness, not making changes together, or the family not being responsive to healthier lifestyle changes. So when we see that somebody in our family is trying to make changes to their diet or their physical activity, we want to make sure that we support them in their efforts and, try to, again, help keep that positive attitude in mind. Next slide. So I'll just open up this question for the group. What are some ways caregivers can help with activities of daily living? And I talked about this a little bit, but when you think about a caregiver, how do we help with just the normal daily things that you do and relate that to diabetes specifically? And feel free to, again, share. That's okay. Quiet group. All right. So next slide, please. So emotional support, again, having that empathy and understanding for what the person is living with in terms of diabetes, helping, again, provide encouragement for lifestyle changes. That type of positive emotional support can be helpful. Cooking, cleaning, shopping, getting medication ready, or reading food labels. Those are types of self-care behaviors that people may be helping with in terms of activities of daily living. The last presentation talked about wound care. It may be that you have a family member caregiver inspect the feet on a regular basis. So that way, if you're not able, the loved one with diabetes, if they're not able to feel that they have a wound because of neuropathy, it could be that the caregiver regularly just kind of inspects their feet and they report that information to a provider. So those types of self-care behaviors can be quite helpful. Next slide, please. So caregiving does have benefits for the person living with diabetes. It can also have benefits, again, for the caregiver too. Caregiving has been shown to improve medication adherence for diabetes. We also find better diet quality, in particular, increased fruit and vegetable intake, lower levels of diabetes distress, and a better A1C. A1C is a 3-month measure of somebody's blood sugar, and we're able to see that that does improve when you have positive caregiving relationships. Caregiver satisfaction has also been associated with the relationship quality and also their social support. So it's also important that the caregiver, again, receives some benefits from this as well. Next slide, please. Next slide, please. You can go to the next one. We're going to now talk about the challenges of caregiving. So caregivers, again, especially if you're a family member in the home providing care, it can lead to, quite a level of burden and stress on the caregiver. Caregiving, again, can happen outside the home, and depending on how the caregiving setting occurs, that may affect the level of stress. But in particular, for those, especially in the home, we can see that this can have a heavy burden. Stress might be related to changing roles, changing relationships within your family dynamics. So if you have a loved one who had previously did the grocery shopping and now they're not able to, now you have to do that. or now you're asked to read food labels because maybe your loved one doesn't have good vision and they're not able to do that. Those are changing roles and things that might change the relationship and dynamic of that, that caregiver and the person living with diabetes. You may have demands that compete. So, again, just thinking about changes in your routine, if you need to be at home for medication dosing or reminding a loved one to check their blood sugar, that may create some competing demands. Caregiving can also lead to isolation, especially if you're, afraid to leave the loved one alone. I use the example of the low blood sugar. If you've had that happen and you're very, watchful of it, that can be a good thing, but at the same time, it might lead to isolation where you feel like you can't leave the loved one, right? So that isolation can lead to depression and have its own stress associated with it for the caregiver. There can be physical and emotional burden. So we're going to talk about how physical and emotional burden might impact the caregiver on the next slides. So caregivers are found to have more stress with daily living assistance. So if they're helping provide, assistance for those activities of daily living, like cooking, shopping, that's going to lead to more stress. Unpaid caregiving is also associated with more stress. Caregiver strain has been linked to less help from family and friends. So it's important that we increase our network and we stay connected as a caregiver. Caregiver strain has been linked to depression for the caregiver specifically. And I mentioned before that a lot of caregivers might be in home, and those caregivers may also have their own chronic disease or their own conditions that they need to manage. And so this might create some, competition for the management of their own conditions if they're providing care to another loved one in their home. Next slide, please. So as a caregiver and a partner, many partners and caregivers may feel that it's their responsibility to manage a loved one's diabetes. This can lead to, again, frustration at times, especially if the person living with diabetes is reluctant to have the caregiver assist with some of the self-care behaviors. Sometimes a caregiver might feel excluded from a discussion with their provider, and they might be uncertain, again, of how they could help their partner or loved one. So not having knowledge can challenge the self-care and the role of the caregiver, and that can lead to frustration over time. Next slide, please. So all caregivers are at risk for stress and diabetes distress. In terms of, what might be some specific risks to think about would be living with the person that you're caring for. Again, having that 24/7 type of caregiving responsibility is going to be a heavier burden. Having limited social contact and support. So again, it's important that caregivers stay connected and they get in their communities and they, have support from family and friends to avoid that social isolation. Signs or symptoms of depression, financial strain on the caregiver, the number of hours spent doing caregiving, lack of choice to be a caregiver. If you didn't choose to be a caregiver, but you fall into the shoes of a caregiver role, that certainly can create some undue stress. Problem solving skills, if they're lacking, or lack of coping skills can also be a risk factor for caregiver stress. So how can you tell if you have caregiver stress? If you feel overwhelmed or you're feeling constantly worried, if you're easily irritated or agitated by something that normally wouldn't bother you, if you're angry or you're losing interest in activities you normally enjoy, if you're feeling sad, or if there is an increase in substance use or misuse, those would all be potentially signs of caregiver stress. And you would want to talk to a primary care provider about that. It is important that as a caregiver, you receive also routine medical care, and your mental health is also considered in that. So if you feel that you do have any of these as a caregiver, it's important, again, that you reach out for help. Next slide, please. It's also important to recognize that stress can be a physical reaction. So it's not only emotional, it can be physical. So caregivers who are seeing changes in their sleep, whether it's sleeping too much or not enough, that can be a sign of burden or stress. If you've had weight changes, it could be, again, weight loss or weight gain, could be a sign of caregiver stress, especially, again, if it's unintentional weight change. I want to make that point. If you're having physical discomfort, which might be seen as body pain, aches, headaches regularly, if you're tired often, those could all be signs of the physical reaction of stress as a caregiver. Again, my disclaimer again would be talk to your physician if you feel that you are experiencing stress as a caregiver. Next slide, please. So caregiver burnout is a real issue. It is so important as a caregiver not to become so enmeshed in the role that you lose yourself. It's neither good for you nor your loved one. And this comes from Dana Reeve. So as a caregiver, you can only provide care if you yourself are well taken care of, right? So it is important that you receive support and you reach out for support during this caregiving journey. Next slide, please. So I'm going to talk for a few slides about approaches to caregiving and some of the studies related to caregiving and how that might improve diabetes management and how that also might have benefit for the caregiver themselves. So a study that included couples calls. It was a telephonic counseling intervention for people living with diabetes, where the couple was included in the intervention group, and there was a group where they received kind of the standard usual care. But for those where the couple was engaged in the telephonic counseling interaction or the intervention, they found that there was improvements in marital satisfaction, blood pressure, and diabetes distress for the person living with diabetes. I mentioned the Dawn 2 study earlier. And at one point I want to make about that study is that some family members have also reported that as a result of, supporting their own family member with diabetes, that helps improve their own lifestyle and behaviors as well. So it can have a benefit there for the family member. It's also important that partners, again, find support from other people who might be serving as a caregiver for people living with diabetes. So we talk a lot about how people with chronic disease need to have peer support, and we talk about support groups. We have a lot of support groups available for people, for example, who have a chronic disease, cancer, or you think about, AA. But then we also have groups like Al-Anon, right, where it's for the family member. So really in a similar idea that people who are providing care or a loved one with diabetes, that they would need to have similar support as well for their caregiving role. Next slide, please. The Look Ahead study was another study that found that when spouses were participating in the diabetes intervention, that the spouses actually lost more weight when they had that participation compared to when they just received kind of the normal routine care. Family intervention for type 2 has also been linked to better A1C, LDL, that's a type of cholesterol, blood pressure. We also see improved knowledge, medication adherence, that means taking your medicine as directed. And then we also see self-management and confidence to manage one's diabetes is higher in the family intervention group. And then the last two lines here, language is important. Studies have found, again, that positive talk and language, how we talk and communicate with the loved one or the family member with diabetes, is really important. And those early family experiences, really early on when somebody's diagnosed with diabetes, will help tell the story of really that diabetes self-care. So early experiences, if you engage the family member early on, that can help with improving coping, family stress, support, and it's been found to predict medication adherence and diabetes self-care long-term. Next slide, please. So how can caregivers cope? So I mentioned this several times. It's important that you reach out, you seek and accept help. So if you do recognize that you may be experiencing signs of caregiver distress, it is important that you ask for help and that you, accept help when it's offered. And may not even always be medical help, but it might be help from family or friends, to let them help take on some of those responsibilities. So it's important that you're able to delegate what you're not able to do. And you have to, identify maybe the caregiving tasks and roles that you can do, that you can provide. So we need to have realistic goals for caregiving. Making a to-do list and prioritizing that can help with your caregiving coping strategies as well. And that may also help you identify the things that are maybe more low-hanging fruit or things that you're not equipped to do that you can hopefully delegate to other members of the medical team or other family, friends, or other types of caregivers who may be involved. Next slide. So there are support groups available, and I would encourage you to, if you see support groups, utilize those. Socialization, walking with a friend can be quite helpful. Finding community resources, and then again, talking to your own healthcare providers routinely is going to be helpful as a coping mechanism for the caregiver. Simple things such as a positive attitude, attending appointments, taking notes, and communicating with healthcare providers can help fill the knowledge gaps to help a caregiver feel more prepared for the role they may be asked to be involved with. Again, it's important that you have that positive and open language and dialogue with your loved one. Mindfulness is a technique that people can use to kind of center their thoughts and really pay attention to how they feel in the situation. Mindfulness is used for nutrition quite often for weight management, but it can have help also for monitoring stress and distress. And there are specific techniques that people can engage in to engage in mindfulness behavior. If you're a parent caregiver of a child with diabetes, you may want to talk to teachers or school personnel again about how their care may need to be provided while they're at school. Next slide, please. So I mentioned before that caregiving can have some positive benefits on your own lifestyle and behavior. And so it's important to talk about your own self-care. So being physically active, making sure that you're getting sufficient rest and sleep. Again, having a positive attitude, a good sense of humor can always go a long way. Eating a balanced diet. And then again, finding time for yourself and knowing your limits can be quite helpful. Next slide, please. So that concludes my talk about caregiving and diabetes, but I wanted to do a quick mention of a new program that we are starting at Bowling Green State University. We received funding from the Bowling Green Community Foundation. So I want to say thank you again to the BG Community Foundation for the support, but we are starting a virtual diabetes prevention program. This will be a free program. It will be done 100% virtually, with the exception of some kind of orientation and wrap-up days. But we are looking to, provide public service to the public as a university. So our services are focused on those living in Wood County and the surrounding area who would not otherwise have access to nutrition and diabetes prevention services. We are specifically looking for those who have a household income of less than $30,000 per year, without health insurance, the underinsured, or those who just transportation may be a barrier, preventing them from receiving nutrition or diabetes prevention services. So next slide, please. I've included the link for information about our diabetes prevention program. We are looking to start in summer of 2021. We are actually ready to roll this out. Our website went live this last week, so we're really excited about the diabetes prevention program. We are asking for a referral from our clients who will be participating. And so if you visit our website, you can actually direct your provider, your healthcare provider, to that referral form. It's an online referral form that your provider will need to complete, and then we'll be able to review your eligibility to make sure you qualify from that referral form. But we're looking for individuals who are 18 years or older, not currently pregnant. You do have to have a BMI that indicates you're overweight to qualify. You have to also have a positive screening for diabetes risk. So you have to be at high risk for developing diabetes, or you may already have pre-diabetes diagnosis. If you have a previous history of diabetes during pregnancy, it's what we call gestational diabetes, that would also be a qualifier. Clients cannot have a diagnosis of type 1 or type 2 diabetes. This is not a program focused on diabetes self-management. It is focused on diabetes prevention behaviors. So if you have type 1 or type 2, or you have diabetes currently in pregnancy, you should again look at programs that provide diabetes self-management, such as that's provided by the Wood County Hospital. So if you are interested, again, please visit the website. It's bgsu.edu /DPP. And we are looking for a start of summer 21. And I'm happy to answer any questions that you may have as well. My contact information is on the next slide, Danielle. Thank you.
Perfect. Thank you so much, Kerri, for sharing that great information. I'm going to kind of open it up to the floor. If anyone has any questions from our participants, feel free to share your questions now. See here. Right. Looks like if they have any questions from future reference, we'll go ahead and I will be able to share those with you. So just as a reminder, we thank everyone for joining our Care Compass project today. This is designed to provide information to our caregivers who are currently caregiving and to those who may caregive in the future. As a reference point, this information will be shared on our YouTube channel so that individuals can access it at their own leisure. So our YouTube channel is Wood County Committee on Aging, Inc. And I want to take this opportunity to thank our partners for this project. The Care Compass project is brought to the community by Brookdale of Bowling Green, Wood County Committee on Aging, Ohio Living, Golden Care Partners, and the Wood County Hospital. Once again, Kerri, thanks so much for joining us today, and thank you for that valuable information.
My pleasure, Danielle. Thank you again for the invitation. It's nice
Thank
to
you.
see you all today. So take care.
Thank you.